with Shabana Ali, who's going to be joining us in a second. And today's talk is very much going to be the third one in the series of webinars that we've been presenting for critical care nursing. The topic of this session today is going to be ARDS and proning. But before we go there, just some housekeeping points. Your handouts are available on the link shown on the PowerPoint. There are going to be videos available, which are the recordings of this on the APPNA Merit web YouTube channel, and you can review them from there. Even if you see those and then fill up the feedback forms, we will still accept that as somebody who has attended. The e-certificates would be available at the end of the 8th session, but we would need to know that you have attended, which sessions you have attended. And there will be a 9th session, which will be very much focused on Q's and A's and whatever might be remaining from the previous talks. So we're going to start by answering some questions from the last session. And there have been questions like, shall we use high flow cannula without CPAP or BiPAP? That depends. Usually the high flow cannula is used before CPAP or BiPAP is being used most of the time. And a lot of places use it. There has been recommendation for using high flow cannulas. Just keep in mind that high flow cannulas can be oxygen dependent. And since they need a high flow rate, if your unit has a lot of people on high flow oxygen, that can potentially compromise the oxygen supply. But other than that, there's no reason why you shouldn't precede CPAP with a trial of giving somebody nasal high flow or high flow cannula. Now I'm going to skip question number 2 and 3, which will be covered by Shabana because that's what she covered in her last talk. Is CPAP used in thoracic surgery? Yes, you can. I'm assuming what you're saying is that somebody has had thoracic surgery, can they be offered CPAP? And the answer is yes, they can. Is TB patient CPAP is contraindicated or not? No, it is not contraindicated, and you can give TB patients CPAP if need be. You will have to take precautions though. You cannot start giving them CPAP in open wards, especially if they are at risk of infection to others. How can we prevent pressure sores on the face due to tightly fitted CPAP mask? Well, there are different things you could do. You can make sure that it's the best fitting mask. So rather than too tight or too little, check the pressure areas regularly. And sometimes what you can do is there are little cushions which you can actually stick to parts of the face where the pressure is going to be, and that dissipates the pressure. And so those can be different ways of addressing pressure from the CPAP mask. And please explain the chest X-ray shown in the last slide. Well, the chest X-ray was not explained in the last session because that's what you're going to get an explanation of when we talk about ARDS today from Dr. Jaffar. And off to you, Shabana.
Yeah, thank you, Dr. Mohsin. Good evening or good morning, wherever the situation may be throughout the world. For me, it's a good morning. I received 2 questions that I covered last time. Dr. Mohsin, can you go back to the question slide?
I can do. Sorry, there we go.
It's about the mask, the reservoir mask that we use. And there was some confusion about non-rebreather mask and a rebreather mask. So I'll be covering these 2 questions in my upcoming talks. Can you change the slide, please? So if you see, this is a mask. We have 4 kind of masks that we usually see. A very simple mask, then a venti mask. I think we all understood the function of venti mask. When you have to give very controlled percentage of oxygen to patient, we use venti mask, and they have specific valves that help controlling the flow or the requirement of oxygen. Now, this is a simple face mask. You see there are 2 valves on both sides, the one in the circle with 3 dots on it, those are valves. So if this mask is put on a patient connected to the oxygen, this is just simple face mask. You just put it on, put it high on a 15 liter, usually 10 to 15 liters, and you give oxygen. But the holes, which are the valves which you see on the side, the carbon dioxide, the exhaled carbon dioxide comes out of that valve. So not very, if you see where the mask is still the air escapes out of the mask, but still patient is getting pretty good amount of oxygen. So if you have a bag connected with this mask down there by the tube, where the tubes are, where the tube is going to the oxygen, and if at that point, if you connect a bag, it becomes either a partial rebreather mask or a non-rebreather mask. Okay. So when we say non-rebreather mask, that means there is a bag attached with the mask and there is a valve on it. So this whole bag is connected to the oxygen on the wall. So all the oxygen from the wall, from the tube is coming and collecting in this little bag, okay? And patient is getting the pure oxygen from this bag going to his either from mouth or nose, wherever the case may be, if it's a mouth breather or nose. And the exhaled carbon dioxide is coming out from the valve, okay? So the function of that valve is it's not going, the air inside the mask is not going back in the reservoir, which is very important feature. So patient is getting 100% pure oxygen. This kind of mask is used during the time when patient is about to code or crash, and you are the physician and you guys are thinking that should we intubate the patient or should we put the mask? You are getting all the medications for intubation. So this is just a temporary attempt to oxygenate the patient. So you just, and the patient is still conscious. Of course, a conscious patient cannot tolerate the ambo bag. So you just keep this mask for sometimes to give a chance to see how patient is doing. So you just put this mask, okay? When I say partial rebreathing mask, you say partial, right? Like not complete. If non-rebreather is not like shut, no. The partial rebreather mask, what we do, you saw the valves which is on the mask, and there is a valve that connects the bag and the mask inside. You just remove all the valves. That's it. And the flow rate is a little lower than the non-rebreather mask. This is the only difference. So the partial rebreathing, yes, there are chances that the carbon dioxide get connected in the bag or outside the mask. So sometimes those patients who are hyperventilating, they are anxious, and you want them to just calm down. And sometimes, the carbon dioxide help for those hyperventilation. You put this partial rebreathing mask, so that helps. But it is not, this reservoir is not to accumulate all the carbon dioxide from the patient. It's just a partial one, okay? I hope I answered your questions, but if you have still any further questions, please let me know. I think there is one more slide back after this that can show you a clear picture of the valve. Now see that the valves that goes on the mask, these two, those are expiration valves. So whatever the carbon dioxide patient is expiring in the breathing pattern, it just goes out. But these valves do not let the air oxygen go in the mask. That is why the purity of oxygen is maintained. And there is a valve by the green. You see the green thing on the back. This is the valve to keep one flow on. So nothing from the mask could go down in the bag, but from the bag it can go up. It's just like a valve, like in the heart. Okay, so it's just a one flow of oxygen from the outlet to the bag to the mask. Okay, so in a very simple way, a face mask है, without a bag, it's a face mask. आप उसमें bag लगा दें और valves लगा दें, it becomes a non-rebreather. But if you remove the valve, it becomes a partial rebreather. Okay, thank you. So in a patient who is saturating 90% on 6-liter oxygen via nasal cannula, what is the next choice of oxygen delivery device? A simple face mask, a non-rebreather mask, CPAP, or an ambo bag? So let's see how we answer this question.
Shabana, can you see the results?
No, I cannot.
I'll tell the results in that case.
Okay.
So it looks like 89% of the people have said simple face mask. Mm-hmm. One person thought a non-breather mask, and one person wanted to give CPAP.
Mm-hmm. All right, you guys got it correct. Most of you, simple face mask. It goes as nasal cannula, face mask, then you go with the non-rebreather or rebreather, and then you go through other extensive modalities for oxygen like CPAP, and then you go through intubation. Great. All right, hand over to you, Dr. Mohsin.
Oh, the case. Okay, fair enough. I can answer this, no problem at all. So we're just going to recap the case now as to what has happened in the past. Let me get my. So Mrs. N was the lady who came to us initially. This lady was admitted, this 68-year-old lady who's a diabetic and hypertensive, was admitted with some shortness of breath and some general fatigue for 3 days. She was febrile at the time of presentation, and it was thought that what was wrong with her was the fact that she had diabetic ketoacidosis. Uh, and so she was admitted to the ward, and it was an incidental finding that she actually had a COVID test done at presentation, which turned out to be positive. Now, while this lady was admitted, we realized that her oxygen demands went from being on 1 or 2 liters to being on, as we say, 6 liters and still not ventilating, so much so that her SATs had gone down to roughly 70%. And at that point, what we had done was we had done two things. Somebody had upscaled her oxygen delivery, and we were considering whether we needed to start her on CPAP. And in the meanwhile, the doctors had requested a chest X-ray and an ABG was done. Now you could see that the chest X-ray shows that there are changes on both sides of the lung, and Dr. Jaffar is going to explain that further in his talk. And the gases themselves were very much suggestive that the oxygen levels are way lower than anticipated. As you can see, the PO2 is only 65, the PCO2 is nearly lower normal limits, but the patient is on a large amount of inspired oxygen. Yeah. So the today's talk, which is basically about acute respiratory distress syndrome and proning, is what's going to address the findings of those X-rays and the interpretation of what is going on, and then hopefully what are the things we can do about it. Okay. Now off to you, Dr. Jaffar. Dr. Jaffar. Okay. Not sure what's going on here. Guys, is Dr. Jaffar there?
I'm calling him.
Okay. So tell you what I will do. Rather than just sit around, we will start talking about. Does anybody have any questions about the things we have covered so far? If you have any questions, please ask now and I will answer them while we're waiting. When will you get the e-certificate? You will get the e-certificate after the last talk is done. So whichever talks you have attended, we will give you a certificate for those talks, but we will only issue them after the last talks is done. Because some of you would be coming for 2 or 3 or 4, so rather than do multiple things, that's what we are going to do. Kindly explain the role of lactate in ABGs. Why lactate in ABGs? Okay, so the thing with lactate in ABGs is because some time ago we came to realize that lactate can be an independent predictor of mortality. I think Dr. Jaffar is here.
Yeah.
And so I'm going to go back to his slide and I will answer that question at the end.
Okay, let me turn off my.
Okay. So yeah, the reason we do lactates is because we know that lactate can independently predict mortality and it's a good marker of cellular stress. So, and for some time it was also used as a resuscitation target in patients with sepsis. Uh, So yes, that's the reason why we do it, because it can tell us a lot more about how worried we need to be and what trajectory the patient might move on to. And off to Dr. Jaffar now.
All right, thank you very much. Okay, sorry about that. I had my you know my laptop on, and I was in the talk, but you guys couldn't hear me. So I think we should be able to. Okay now. All right. So can I move the slides or not? Okay.
So Jaffar,
So
I'm going to move your slides for you. If you say next slide, I'll move.
okay. Thank you very much. Okay. So we have this female patient who has been in the ICU, and now she continues to feel unwell. She's confused, and occasionally she's agitated. She is more short of breath and using her intercostal muscles. So most of the time we are using our diaphragm to breathe. When we start using our accessory muscles to breathe, that means that there's a problem. So especially the intercostal muscles or the neck accessory muscles, if we start using those muscles, then we know that the patient is getting, number one, that most likely is reaching towards where it needs more help. And that will be in the form of either CPAP, BiPAP, maybe endotracheal intubation, or somewhere we need to go. So those patients, most of the time when we are breathing, our flow rate, which is going in, taking in oxygen, is between 15 to 30 liters per minute. And when this flow rate increases, when the patients are short of breath or they are breathing 30 times a minute, and their flow rate will go up from 30 to 60 liters per minute. And that actually, gets them into trouble because they can't keep up with that flow rate, as well as the muscles, or the intercostal muscles and the abdominal muscle, they start getting tired. And so our patient, she is on high flow nasal cannula at 15 liters per minute with a humidified oxygen. Respiratory rate is 34 per minute, and pulse ox saturation is 94%. And we can see that our patient is in trouble. The patient was started on dexamethasone, which was 6 milligram orally. And can we move on to the next slide, please? So white cell count is 7,000 and platelets are 78,000 hemoglobin. And you can see that the creatinine has gone up a little bit, with a potassium of 4.2, chest X-ray, which is showing bilateral infiltrates. So when you look at this chest X-ray, most of the time, when we look at the normal chest X-ray, we will see kind of very radiolucent areas of the lungs, because the radiations can go through the air dynamics. And basically, if you look at the top of the lung, and that is much more area where air is, you can see that. And if you look at the bottom of the lung on both sides, these are radio opaque area where there is a consolidation, there is some fluid there, there's everything basically which is causing that to look like much more whitish areas. Just like if you look at the heart shadow, which is much more white as compared to the lung, you see some areas which are dark and the other areas which are whitish. So that is not a normal lung, normal looking lung. So normal looking lung is just like with the top of the areas. And in the middle, you can see that there is a trachea, and the trachea bifurcates into the right and the left main stem bronchus. And now you should be able to see that. And thank you, Mohsin, for moving this slider. So if we can move next. So we have a question here. So which finding below is a hallmark of a patient who is with ARDS, basically someone who is developing ARDS? So
Okay, so we have got the results of the poll.
Okay, so about 55% people actually answered C, where the PaO2 is of the arterial blood gas remains 55 despite higher concentration of oxygen. So that's the answer. So most of these patients who are developing ARDS, their respiratory rate will go up. Yes, they will be tired, confused, and with altered mental status, but that is not the hallmark of ARDS. Any patients who is developing any acute infection, or they may be developing, let's say they are COPD, or they may have, or maybe any other disease process, they will have that kind of a presentation. So that's not the hallmark. Refractory hypoxemia, if you can make a next click, just click one time. Oh, okay, here we go. So refractory hypoxemia is as the PaO2 less than 60 millimeter of mercury for at least 1 hour while receiving an FiO2 of 1 or 100% oxygen. So patients who are getting 100% oxygen and they do not respond to that higher concentration of oxygen and their PaO2 remains below 60 millimeter of mercury, then we know that these patients are actually, they have refractory hypoxemia, and you keep on going up on oxygen and they're not going to respond to it. Next slide. So another question. Okay, so answer is C. 37% of the respondent actually gave the true answer. So patients who have developed or who have ARDS, there are 4 things that we want to make sure they are present. One is it is acute onset. Number 2, that as we talked about in the previous slide, they have refractory hypoxemia or hypoxemia at different levels with the PaO to FiO2 ratio from mild to severe. They have diffuse bilateral pulmonary infiltrates, and they have non-cardiogenic pulmonary edema. So that's the difference between patients who have congestive heart failure or patients who have ARDS. So they have a non-cardiogenic pulmonary edema as compared to cardiogenic pulmonary edema. Now, there are patients who have developed or who have history of congestive heart failure who may come in with a pneumonia or COVID pneumonia, and they will have some components of a cardiogenic pulmonary edema, but that's not the hallmark. So most of the patients who have ARDS, they will have acute onset, refractory hypoxemia, diffuse bilateral infiltrates, and non-cardiogenic pulmonary edema. Okay, next one. So there are 3 different types of hypoxemia basically in these patients: mild, moderate, and severe. So if we look at with mild, with the PaO2 FiO2 ratio 200 to 300, moderate will be 100 to 200, and then severe less than 100. So how do we calculate this PaO2 FiO2 ratio? From the blood gas, you get the arterial oxygen, which is maybe normal is between 90 to 95 millimeter of mercury, and FiO2 is between 0.2 all the way to 1.0. So any patients, we are all on room air. So if, let's say, if my PaO2 is 90, with which is divided by FiO2, which is 0.2, so that means my ratio will be 450. So any patient who has a ratio less than 400, they have a disease process going on. So mild, moderate, and severe, depending on this, we can actually say that the patient has mild ARDS, moderate, or severe ARDS. Next slide, please. So what causes ARDS? There are two different causes. One are direct, any direct insult to the lung, and there are others which are indirect causes of ARDS. So direct insult to the lung will be any pneumonia, which is viral or bacterial, any patient who has developed aspiration pneumonia or aspirated gastric contents, and they develop pneumonia, either it is chemical or later on can become bacterial. Pulmonary embolism with massive pulmonary embolism, which is again direct insult to the lung, or patients who have inhalation burn injuries, could be from a burning house or from where they are coming in. And those patients might develop direct ARDS. And then there are indirect causes of ARDS, where severe sepsis or septic shock, and sepsis can be from, let's say, urinary tract infection or pyelonephritis, and they develop a systemic inflammatory response, and that systemic inflammatory response is going to give rise to indirect leakage of all the fluid into the pulmonary alveoli, and then causes that ARDS. Same thing with the massive transfusion, pancreatitis, deperfusion syndrome. So all these different type of syndromes, which are not directly in the lung, but they are causing indirect injury to the lung. Okay, next slide, please. So we look at what are the changes that happens in the lung when we look at the chest x-ray. If you look at on the right, the chest x-ray, you see areas of the lung which are normal looking, and there are other areas of the lung which are abnormal looking. So we call it kind of a ground glass appearance of the lung, where some areas of the lung will look at much darker as compared to the other areas of the lung, which are actually less darker or more whitish. So there is why there is a reduced lung functional lung areas because of atelectasis. So atelectasis are going to happen. Does not mean that any patient who develop COVID pneumonia will have atelectasis. Atelectasis can develop actually anytime in us as well. When you go from upright to supine position during the night when you're asleep, some areas of our lung develop atelectasis because of the gas exchange in those areas of the lung are not going to be as good as some other areas of the lung. So we have 3 zones of lung: zone 1, zone 2, and zone 3. We are not going to talk about those now, but depending on the ventilation as well as perfusion to those areas of the lungs, we develop either dead space ventilation or shunting. In atelectasis, there is more shunting happening because of the areas of the lungs which are closed, and alveoli which are closed, but the blood is flowing through those areas without getting oxygenated. And then there are different amount of air in different zones of lung, as I said, from zone 1 to zone 3, depending on which zone, the lung zones we are in. And then there is going to be, again, gas exchange abnormalities because of the ventilation and perfusion mismatch. So there are areas of the lungs where more ventilation is happening, and most of the time these are the zone 1 lung. And then there are areas of the lungs where more perfusion is happening, which are mostly zone 3, or sometimes we call zone 4 lung. Okay, next one. So this slide's basically, this is a CT scan of a patient who is developing kind of a severe ARDS. If you look at the slide on A, where the patient is much more closer to the center, there is normal areas of the lung, and on the periphery, you can see some fluid which is accumulating into the peripheral areas of the lung, and that is initial signs that you see in on a chest CT in patients who has COVID pneumonia. On the second slide, slide B, now most of the lung is now fluid filled, And you can see actually much more areas of the lung which are now with all the fluid-filled cavities. And as the disease worsens, now those fluid-filled cavities now become consolidated. And you can see much more areas of the lung which are now consolidated as compared to very small areas of the lung which are being ventilated. And then the fourth one is even the worst one, where it's now very small areas of the lungs are left with the where aeration or ventilation and perfusion can happen. And most of these patients are now in a situation where they are on 100% oxygen, but their PaO2 is less than 60 or less than 55 or 50. So these are the patients who are, we call them happy hypoxemic. And they are sitting there with a pulse ox saturation of 80 and breathing 25 to 30 times a minute and talking to you, but their lungs are looking that bad. Okay, next slide, please. So these are 6 P's of nursing care. And when I'm talking to our nurses in our ICU, I'm always looking at these 6 things, that what is going on with the patient. So number 1 is perfusion. Number 2, positioning. Number 3, are we using protective lung ventilation or therapy for these patients who are being mechanically ventilated, or maybe non-invasive mechanical ventilation? Protocol meaning even if we are using non-invasive ventilation mode of ventilation, it could be a BiPAP or CPAP, or could be high flow nasal cannula. Do we have developed any protocol to how we're going to wean this patient off oxygen? Because whenever a patient is on 100% oxygen, the lung also get damaged because of 100% oxygen as well. And then nutritional status of the patients. We do want to make sure that these patients are being fed every single day. Just like every one of us, we have 3 meals a day. If we don't have, even if we skip a breakfast, we feel like, oh, I need to eat something. But sometimes, we keep these patients for 48, 72 hours without any food, and we think that they can survive. They will never survive. And then we want to prevent any complications, especially GI bleed, which is common, again, because of stress-related gastritis. We want to pressure sores in these patients. We want to suppress any DVT or pulmonary embolism later on. And then many other complications which can happen, especially those who are intubated, so they can develop ventilator-associated pneumonias or secondary bacterial infections. These patients have central lines. We also want to make sure they don't develop central line associated bloodstream infections. These patients also have, again, many things can happen to our patients. So we want to prevent those complications. So remember these 6 P's, and they're going to be discussed in the next few talks that are going to happen. But today, we're going to talk a little bit about perfusion, and then we're going to talk about positioning. The other 4s are going to be discussed later in different talks. Okay, next slide, please. So how do we assess perfusion? Very simple things. We are looking at the patient's either blood pressure, either we are monitoring continuously with an arterial line, or we are monitoring with a blood pressure cuff. We want to make sure the patient's mean arterial pressure is greater than 65 millimeter of mercury, or systolic blood pressure is greater than 100 millimeter of mercury. Now, there are patients who are living with a systolic blood pressure of 160, 170, or 180, and never had their blood pressure controlled. For those patients, you do want to have a little bit higher systolic blood pressure, maybe 110 to 120, and mean arterial pressure around 70 to 75 millimeter of mercury. Capillary refill. That's a very simple, test that can be done at the bedside, and you can just simply press on the nail bed and look at the refilling of that nail bed. If it's less than 2 seconds, then you know that this is normal perfusion. That means this patient have good cardiac output. I actually, whenever I go to bedside of my patients, I touch their feet If their feet are cold, then I know that there is a perfusion issue, especially the big toe. If the rest of the foot is warm and the big toe is cold, I take it very seriously and I say, okay, there is a problem. So simple things can actually give us a good clue that there is a problem with the patient. So touching is very important. Urine output, which is also a very sensitive indicator that there's something going on with the kidneys. Because if the perfusion, 20% of the cardiac output goes to the kidneys. And if the cardiac output is low, then the kidney output is going to be lower. So we want to make sure somebody who is 70 kilogram person, we want to make sure that that patient is making at least 35 ml per hour of urine. So having hourly urine output measured is very important for these patients, so that we know exactly when the patient's urine output drops, then we know that there is a problem with the perfusion. So either it could be related to the volume, that means we need to give more crystalloids, or it is related to the cardiac output. That means we may have to start the patient on some inotropic support. Pulse pressure variation, which is very simple. You don't have to have actually any invasive monitor. If you have an arterial line or you have a pulse oximeter, if you look at the baseline, normally during inspiration, as we generate negative pressure into the chest, with that, you will see drop in your arterial waveform. And as soon as you expire, you are generating more positive pressure. So you will see a difference between inspiratory to expiratory waveform on your arterial waveform, as well as on your pulse oximetry. If you see that variation, which is normal, if it is less than 10 millimeter of mercury of pressure change. But if it is higher than that, then we know that there is a volume problem in these patients. So there is also another thing that you can do at the bedside, which is a straight leg raise. So somebody who is hypotension, that means their blood pressure is less than 90 millimeter of mercury. And if you want to know that patient is going to respond to your fluids, you can raise both legs of the patient to about 45 degrees and keep it there for 30 to 45 seconds. If the blood pressure improves 10 millimeter of mercury, so it goes from 90 systolic blood pressure to 100 millimeter of mercury, that means that patient is going to respond to your fluid challenge. But if the blood pressure does not change, then you know that there is a problem other than fluids. So you give volume to that patient, those patients develop more congestive heart failure, and they develop more further disease. So you want to make sure that you want to know if your patient is fluid responsive or fluid resistant. And depending on that, then you give your fluid challenge. And you can also look at the serum lactate level, which is a kind of general measure of a perfusion issue. So anyone, normally we have a serum lactate less than 2. So anything above that, then we know that there is a perfusion issue. Again, it could be related to the volume. That means the patients need more crystalloids or colloids, or the patient may need more inotropic support, just like dobutamine or milrinone, or we may have to raise the blood pressure up by giving some vasopressors like norepinephrine or noradrenaline. Okay, next slide, please. So the next, so we talked about perfusion. Now the next one is positioning. So can you please go to the next? Okay. So most of the ICU patients, when they are with multiple things going on, especially those, the sickest one, they are intubated, they have multiple lines in place, as well as, and a lot of times nobody's moving them. And that is the time when they develop pressure sores as well. So we are using, there are so many devices. Simple thing is that every 2 hours, turning the patient to their sides. That is a very simple maneuver that most of the nurses know how to do it, and they turn them on side to side to remove the pressure sores. But in patients who have severe ARDS, we use sometimes kinetic therapy, we use continuous bilateral rotationary therapy, and these beds are very expensive, as well as these require very skilled nursing care, because you can see that the bed completely turns onto the side, and if the patient is not secured in that bed, then the patient can easily fall. And then the third one is prone positioning, especially for ARDS patients, where we are always, if our simple maneuvers are not working, then we know that proning them is going to help us to change the ventilation and perfusion areas of the lungs. And from here onward, I think Nasreen is going to be talking about positioning, especially proning. Let's move on to the next slide, please. Okay, thank you very much. And then I will come back in the end. Okay.
So thank you so much, Dr. Jaffar. And now we'll be discussing prone position ventilation. Next slide. Yeah. So what is prone position ventilation? It is a non-invasive way to optimize oxygenation in patients with severe hypoxic respiratory failure from ARDS. And this can be seen through this chest X-ray. We can see that the lungs are so occupied with the infiltrates and with the fluids in ARDS, and the lungs are have this fluid accumulation. So at this point, this prone position ventilation can be used as a non-invasive way to optimize oxygenation in patients who have severe hypoxia due to ARDS. So next, please. So this prone positioning can be used as a rescue maneuver in these patients. Next. So as Dr. Jaffar discussed about the effects of ARDS on the lungs and the lung tissues, we know that ARDS induces many changes in the lung mechanics and in the lung ventilation. So fortunately, prone position ventilation helps us to address these changes which are induced by ARDS in the lung mechanics and lung ventilation. So one of the physiological impacts of prone positioning is improvement in the lung compliance, and that occurs by improving the alveolar inflation, right? So here we can see that there are two patients, right? One is in supine position and one is in prone position, right? So we'll first discuss the supine patient in supine position. So we can see that we all know that we have comparatively larger ventilatory surface available at the dorsal lung field, which is this one. Can you please point here? So the dorsal lung field has the larger ventilatory area as compared to the ventral surface, right? We can see that here in the picture as well. The ventral surface has a lesser ventilatory area than this dorsal surface, right? So this means at the dorsal surface there are more alveoli because of its size. But in supine position, what happens is there are several compressive forces by the diaphragm or by the abdominal organs, and we can see in this picture by the heart as well. So these organs exert several compressive forces on the dorsal lung field, due to which the alveoli in this dorsal lung area, which is now the dependent area, do not get enough space for inflation. And when they do not get this enough space for inflation, the alveoli cannot inhale adequate tidal volume. And due to this, the tidal volume of a person decreases, and the functional residual capacity also decrease. But as soon as we prone the patient, as soon as we turn the patient upside down, we can see that the diaphragm has dropped down as well, and the heart has shifted forward. In the previous picture, we can see that the heart is, can you please put the pointer on the heart in the supine position? Yeah, on the heart in the supine position. So the heart in the supine position is here, but when we prone the patient, the heart shifts forward here, right? So this is how the compressive forces of the diaphragm and the compressive forces from the abdominal organs and the heart decrease on the dorsal lung field. And we have alveoli here on the dorsal lung field is now at the independent surface, right? So the alveoli get enough space for expansion. And once the alveoli are getting this enough space for expansion, they can inhale adequate tidal volume. And by inhaling adequate tidal volume, we will have increased functional residual capacity, and ultimately the lung compliance after prone positioning will improve. Next. So homogeneity, which means that fairly equal. Homogeneous, the term homogeneous means equal, right? So homogeneity means fairly equal ventilation. Now, before explaining you this slide, I would like all of you to recall the slide which Dr. Jaffar explained, the slide which had 4 different CT scans, right? Yeah, so in those CT scans, we could see that some areas were black in color and some lung areas appeared white. Why did this happen? It was because the accumulation of the secretions, um, uh, the alveoli which are accumulated with secretions cannot receive proper ventilation, right? And now let's see here in this picture. This is the complete lung, right? This is zone 1, this is zone 2, and this is zone 3. So we have this is the apex of the lung, and this is the base of the lung, right? So in zone 1, we can see that the alveolus is comparatively bigger in size than the alveolus present in the zone 2. And the alveolus present in zone 2 is bigger in size as compared to the alveolus present in the zone 3. So this difference in size basically also affects the distribution of ventilation. So if we move from the top of the lung, from zone 1 to the bottom of the lung, there we will find differences in the ventilation, right? We know that air travels up, right? Can you please move the slide? I mean, can you please click for the other picture? Yeah. So we can see here too that the alveoli which are present on the in the independent area, that is in the upper area, are more inflated, and the alveoli which are present in the dependent area are comparatively deflated, or they're not as inflated as the alveoli which are present in the independent area, right? So what happens here is, one thing is the size of the alveolus depending upon the inflation. As soon as the all right, one minute. So yeah, we can see this alveoli. We have a bigger alveoli in the zone 1, right? So if the ventilation will, as soon as the air travels in the alveoli in the zone 1, the alveoli has enough space to expand, right? But if the air will travel in zone 2 and zone 3, the alveoli do not have enough space to inflate. So this is how the ventilation in the upper portion or in the upper zone will be highest as compared to the ventilation in the middle and in the lower zone, right? Secondly, we know that this is a lung which has ARDS. So we know, and Dr. Jaffar has finally explained it, that the lungs in ARDS are consolidated, and the alveoli in the lower or in the dependent areas are usually filled with secretions, right? Why the alveoli in the dependent area are filled with secretions? It is because of the influence of gravity, right? The gravity pulls the secretion down and pulls the secretion down in the dependent surfaces. So so there are two things happening. One, the inflation of the alveoli in the upper surface is highest as compared to the lower surface. And second, the alveoli in the lower surface, in the lower area, all have secretions, due to which they cannot take further ventilation, or they cannot take further air. So this is how, can you please move the slide, bring the other animation? Yeah, so we can see that when we will prone the patient, right? In ARDS, this is how the heterogeneity occurs, or the difference in the ventilation occurs, right? The distribution of air is not equal in all the lung fields in ARDS. But as soon as we prone the patient down, what happens is, firstly, as we discussed in the previous slide, the alveoli on the dorsal surfaces on the dorsal surface come up, right? And as soon as the alveoli in the dorsal surface come up, they get enough space for expansion. Secondly, the gravity pulls the fluid down now in the dependent area, and now look, the dependent area here is the ventral surface, and it is not the dorsal surface, right? So the gravity also pulls the fluid down in the ventral surface. So this is how we get majority of the dorsal area, which is now the independent area, free for ventilation and free for alveolar expansion. So this is how prone positioning helps us in homogenizing the distribution of ventilation. Homogenizing means it helps us in distributing the ventilation and air equally, fairly equally throughout the lung fields. Next. Yeah. So third is the improved ventilation perfusion relationship and reduced shunting. So in the previous slide, we have already discussed that the ventilation in the upper in the zone 1 is the highest as compared to the ventilation in zone 2 and zone 3, right? So let's first discuss about the ventilation and perfusion. This V indicates ventilation, and this Q indicates perfusion. Now, ventilation is the supply of air or supply of gas to the alveolus, and perfusion is the supply of blood to this alveolus, right? So the average VQ ratio is 0.8. Now let's see this picture. If we move from the top of the lung to the bottom of the lung, we see differences in the VQ ratios as well. Why? The first reason we already discussed was the difference in the ventilation. The second reason is the difference in the perfusion as well. Now, how this perfusion differs in 3 different zones of the lung, let's discuss it. So if we see the anatomy of the heart, this is the heart and lungs, right? So this is the heart and this is the lung. So we can see that the upper portion of the lung is above the level of the heart, and the lower portion of the lung, the zone 3, is below the level of the heart, right? So as soon as the heart pumps the blood to the lung, the gravity pulls the blood down, as the gravity was pulling the secretions down. So similarly, the gravity has an influence has the influence on this perfusion as well, and the gravity pulls the blood down, and the lower area and the lower portion of the lung is supplied by highest blood flow, right? So the blood flow, we can see this in the picture, that in zone 1 we have lowest perfusion, but as we discussed earlier, we have highest ventilation, right? Then in zone 2 we have moderate perfusion and we have moderate ventilation as well. But in zone 3 we have highest perfusion because of the effect of gravity, and we have lowest ventilation. Why lowest ventilation? Because the alveoli in zone 3 are really collapsed because of the accumulation of the secretions in ARDS, right? So in zone 3 the alveoli are collapsed, but they are provided with the highest blood flow, right? So here what is happening, the alveoli in zone 3 are getting adequate perfusion, they are getting highest perfusion, but the ventilation part is negligible because the alveoli are completely collapsed and they are not able to receive adequate ventilation. So this presence of perfusion without ventilation is called shunting. And that is why in ARDS we have highest shunt fraction, right? But as soon as we will prone the patient, please, next. Hello. Yeah. So in ARDS, when we prone the patient, what happens is, please get that slide back. Yeah, thank you. So as soon as we prone the patient, what happens? The perfusion of the anterior and the basal lung surfaces also improve, right? We can see the difference in both of these things, right? The anterior and the basal surface is receiving the blood now, which it was not receiving properly when the patient was not in prone position. Secondly is that as we discussed earlier, there are less compressive forces on the dorsal lung field, which is the independent lung field now. So the alveoli get adequate space for expansion and alveoli get adequate space for ventilation, right? So here ventilation has also improved and perfusion has also improved. So we have improved ventilation and perfusion relationship, and we have decreased shunting, because the blood now, the alveoli are getting ventilation as well, and now they are being perfused simultaneously too. So this is how prone positioning helps us in improving ventilation to perfusion relationship. Next. So yeah, you have a question here. Which statements is or are true? There can be more than one statement, right? The top is best ventilated and worst perfused. The middle is less ventilated than the top, but better perfused. The top is least ventilated, but best perfused, and all parts are equally ventilated and perfused. Excellent. So all the three answers, like the first one, the top is best ventilated and worst perfused. Then the middle less ventilated than the top, but better perfused. And the bottom is least well ventilated, but best perfused. So these are the right answers. And why all parts are not equally ventilated and not equally perfused, we discussed it, right? In ARDS, we do not have homogeneous, we do not have equal ventilation and perfusion in all parts of the lungs. But as soon as we prone the patient, this inequality in ventilation and perfusion is resolved gradually. So this is why the first three options were right. Next. Next slide, please. Yeah. So now the question arises, when to offer awake proning. Now here the word awake is very, very, very important. Why are we saying awake proning? Because the patient has full GCS right now, right? The patient is not confused. The patient is not disoriented, or the patient GCS is at this point in time, he is oriented to time, place, and person. And yes, the GCS is full, and he's able to follow the commands, right? So we have to offer awake proning when the patient has pneumonia, and that pneumonia could be because of COVID-19. And secondly, if the requirement for FiO2 exceeds beyond 28%. So this is basically a guide for the nurses that all COVID-19 patients with FiO2 greater than 28% should receive awake proning, right? So in the role of a nurse, it is very important first to identify and to be sure that there are no contraindications to proning. Now, what could be those the potential contraindications to proning? Yeah. So this could be morbid obesity. If the patient is obese, we won't offer that patient conscious proning. If the patient has low GCS, then might not offer conscious proning to the patient, because we may intubate that patient rather offering them awake proning. Similarly, if the patient is delirious, the patient will not able to understand our commands and will not able to follow the commands. And based on the CAM scoring, we may put the patient on invasive mechanical ventilation rather than offering him or her awake proning. Then if we have pressure sores on the dependent areas, meaning if we have pressure sores, or if we have any kind of wound on the ventral body surface, then definitely we will not ask that patient to turn upside down on his dependent area, because the dependent area has sores and wounds, right? Then if the patient is pregnant, then definitely we will not, we usually don't offer patient proning. If a patient has respiratory distress, or a patient is hypotensive with a systolic BP of less than 90, we do not offer proning, and we may first try to make that patient hemodynamically stable, and then we may go for proning. So okay, you can remove this box. So once we are sure that there are no contraindications to proning, we ask the patient to change his or her position, right? In this case, please remove this particular animation. And bring that picture back. Yeah. So in Mrs. N's case, we may, being a nurse, I may offer her that, please, Mrs. N, turn to your left lateral recumbent position. And since she's awake and she's able to understand and follow my commands, I will ask her to stay in that position for 30 minutes to 2 hours. And if and I will monitor her in that position. And then if she remains stable, then I may ask her after 2 hours, or after between, I mean, maybe between 30 minutes to 2 hours, I may ask her that to change her position to right lateral recumbent then. And then I again may ask her to stay in that position for 30 minutes to 2 hours. Then again, I will ask her to change her position upside down and come in prone position and stay in that position for 30 minutes to 2 hours again. And then in the Fowler's position with the head of the bed elevated, note this word, with the head of the bed elevated to 30 degrees to 60 degrees, and stay in that position for 30 minutes to 2 hours again. So with every position change, it is very important, with every position change, a nurse must check for the mask leaks if the patient is on face mask, or on the non-invasive ventilation, or on high flow nasal cannula. So a nurse must check for the mask leaks. She must check that the oxygen is still connected even after changing the position, and check that the cannula is not on the dependent side, on the dependent area, and check that the catheters are not compressed, right? Repeat like once we have changed the patient's position, then repeat observation, monitor that patient after this position change, right? Monitor after 15 minutes, right, of that position change. If you find no improvement in that position, then you may ask the patient to try another position, right? And again check the patient after 15 minutes, right? If after a different position, after trying different positions, that patient is still not responding positively, or still patient is deteriorating, then we may seek medical review, and together with the doctors, the nurses, like both of us, the doctors and the nurses, can discuss and then come up with some other plan. Maybe the patient at this point in time may needs invasive mechanical ventilation. So yes, we have to seek the medical review then. Secondly, if there is morbid obesity in patients, then we may consider reverse Trendelenburg position for these patients, right? So what are the general rules? The general rule is to assess the patients on the basis of NEOS score, right? And chart IO, that is monitor the intake and the output of the patient. And the final one is to
Apologies, I do not know what happened to Nasreen there, but what she was about to tell you guys was, if the patient falls asleep while you're proning them, there's no need to change that position to hourly. So don't wake them up just to change their position for proning. And from that, we can go on to the next slide.
hello.
Nasreen, are you back?
Yeah,
Wonderful.
something
I've
happened, I
just told
guess.
them about sleep and proning, and you can go to the next slide.
Yeah, all right, thank you. So with all these interventions, nurses are also responsible to monitor the vital signs and assess for the signs of impaired perfusion and assist the patient during pronation. So to help them or to make this pronation easy for them, then put the side rails up to avoid unwanted fall and unwanted injury. Monitor for aspiration, keep suction and emergency equipment ready. These two things should be readily available when we are pruning the patient. Then monitor for body mechanics and invasive lines, that there is no accidental dislodgement of the invasive lines and the mechanics are fine, and the extremities are not hyperextending, or they are in comfortable position. So assess for the need of non-invasive ventilation and a high flow nasal cannula. And if the patient is already on NIV and a high flow nasal cannula, then maybe we can assess for the requirement. Maybe now the patient require higher support and higher NIV support, or now maybe the patient is improving, so we may decrease the NIV support. So a nurse must be looking for these conditions as well. And plus ensure that the call bell is in easy reach of that patient, so that the patient can call us whenever he or she needs, right? Next. Next slide. Yeah. So you have a question here. Whom would you consider offering awake proning? Any patient with COVID infection and FiO2 greater than 28%, all patients with COVID infection on CPAP, all patients who can't be offered CPAP, all patients with BMI of greater than 35, that is morbidly obese.
For some reason, we don't seem to have the poll launched. So if you guys are answering in the chat box, I'll have a look at that. Okay. Well, I can tell you from the answers which are coming so far, most people have chosen option A, and some of them have actually chosen option C. But by and large, option A seems to be the one that everybody is clicking on. Yep.
So yeah, you people got it correct. At least most of you people have got the answer correct. This is option A, any patient with COVID infection and FiO2 greater than 28%. We discussed it as a nurse in the previous slide that if the patient has pneumonia, has developed pneumonia because of COVID-19 or because of any other infection, but the patient has pneumonia and the requirement of FiO2 exceeds greater than 28%, then we offer awake proning to those patients. Next. Yeah. So how soon after proning a patient should be a patient should you consider repeating the observations? 15 minutes, 5 minutes, 30 minutes, and 60 minutes.
Again, I
Do we have a
think
poll?
that the poll is not working. So if you can answer on the chat box, that will be great. Okay. So to be fair, the most common answer at the moment is C. Second most common answer is A. And a few people have actually put down B as the answer.
All right, so I think this needs explanation. So the correct answer is A, right? Soon after proning. Okay, read the question again. So soon after proning a patient, should you consider repeating the observations? I am talking about the observation. I am not talking about the change of a position. Once you have proned the patient, once you have put the patient in upside down position, you observe that patient after 15 minutes for hemodynamic stability, right? If the patient is hemodynamically stable and comfortable in that position, then we continue that position for about 30 minutes to 2 hours, right? But if, for example, after 15 minutes, we saw that the patient is not comfortable, or there is some problem occurring, or maybe the PF ratio has decreased, or maybe the patient is desaturating, then we may ask that patient to change his position again, right? So we will monitor the patient's condition after 15 minutes of pronation, and if the condition remains stable, then we may ask the patient to be in that position for 30 minutes to 2 hours. So I hope this is clear now. Next slide, please. Yeah. So contraindication to proning a patient with COVID-19 pneumonia is all of the above except, so which is not the contraindication of proning. So yeah, we have a poll here. BP of less than 70 systolic, increased intracranial pressure, head trauma, GCS of 15 as the patient is awake, which is not the contraindication. Yes, most of you have got the answer correct. GCS of 15 by 15 is not the contraindication for awake proning, because here the patient is awake, patient is responding to your commands, patient is following your commands. So here we can ask the patient to change his position. We may ask the patient and if he's not comfortable in that position, that patient may reply as that yes, this position is not comfortable, or so this is GCS of 15 by 15 is not the contraindication for proning, right? The other rest of the things are the contraindications for proning. Next slide. Yeah. So, for example, we have the patient was conscious, and we offered that patient conscious proning, and still we found that this patient is not responding, or the patient's condition is continuously deteriorating, and the PF ratio is on declining trends, and the oxygenation is deteriorating. So now at this point, we may need to put the patient on invasive mechanical ventilation, right? But here again, after putting the patient on invasive mechanical ventilation, after intubating the patient, we have a chance to prone that patient with this ventilator and with this OETT again, right? So now it becomes, this intervention require alertness of the team, because anytime any of our point which will not be, or intervention which will not be supportive, will lead to patient's deterioration, right? So to prone the patient with to prone the patient with invasive mechanical ventilation and with OETT, we need to follow these 5 Ps. So we'll be discussing each of these 5 Ps in detail, right? So first is to prepare, right? In preparation phase, we will need a group of people. 6 to 7 is the ideal number of people which should be present while we are proning the patient, because here in a nurse individually will not be able to prone the patient, right? We will need a complete team of 6 to 7 people to prone the patient. Secondly, we will need all these equipment before proning. Like there should be a slide sheet, 6 pillows, 1 bed sheet, red bungs, eye tape and pads, ECG darts, tube ties, spigots, and head jelly. So after gathering all this equipment, a nurse should ensure that that the patient is neat and clean. She should ensure hygiene care before pronation, that the that the diaper is not dirty, and that the OETT holder is clean, and the patient is really clean at this point in time before you prone the patient, right? Then secondly, she should ensure that the patient is hemodynamically stable. For example, if patient is hypotensive and we are proning the patient, he might end up uh, in maybe in arrhythmias, or in more deteriorating condition. So it is important to ensure that the patient is hemodynamically stable, and if he's hypotensive, then we can start vasopressors or inotropes according to the patient's requirement, right? Then stop enteral feeding and check for residual volume, and evacuate the stomach in order to avoid aspiration of the feeding. And once you have proned the patient, then we can start NG feeding again once we are sure that the airway is secured, right? Beside this, we need to be sure that the patient is adequately sedated and paralyzed, and the eyes are taped close to avoid pressure on the eyes, and all the tubes are tied properly so that the tubes do not get accidentally dislodged, and that NG feeding is stopped and disconnected. CVP transducer is disconnected so that we could avoid the accidental dislodgement of CVP. Urinary catheters are disconnected and spigoted, and all unnecessary infusions are removed. It is just to be sure that maybe the running of the unnecessary infusions, this may lead to accidental dislodgement of the CVP line. And then remove ECG dots from the ventral surface, because now the ventral surface will be dependent, and we will have to put the ECG dots on the dorsal surface. And then the BP cuff is disconnected, and the A line, like every line is disconnected, so that at this point in time during pronation, the lines do not get accidentally dislodged, right? So once we are done with prepare, then comes the next P, and that next P is to plan, right? Here we have to plan that how will the pronation take place.
Sorry,
So
Nasreen, we only have 5 more minutes.
okay, so here we have to plan that there should be a team leader who should be guiding the team, and the team should be listening, and the team should know about the movements, about the direction, and about the number of movements, right? There should be a person standing on the head and should be monitoring the airway, for example, if the tube gets accidentally dislodged. So we should know what to do. Then there should be two people on either side of the patient, in the upper trunk of the body, and then two people should be there in the middle, near the pelvic area, and two people should be there on the leg. So these stars show the placement of the pillows. Pillows should be placed under the chest, two pillows should be placed under the pelvic area, and two should be placed under the leg area. And the placement of the pillows should be adequate enough that they do not that they do not impede, or do not hinder chest expansion or abdominal expansion, right? And they are at a height enough so that they could make the patient free of sores. Then is to perform, maybe we decide that on the count of 3 we will be performing proning, and during pronation we should check for ventilation and reconnect all the monitoring once it is complete. Then P for protection. In protection, we have to be sure that the patient is protected from all the accidental dislodgements, and then that the areas are pressure free, and cables are not trapped, and the arms and the position of arms and position of head should be changed every 2 hourly to avoid the development of pressure sores on these dependent areas, right? And then final P is the P for perfect. And here at this point we are looking that everything which we have done is perfectly done, right? It is perfect on that position. So starting with the pillows, maybe the pillows are perfectly placed and that they are not hindering the chest expansion, and the OETT tube is not kinked, and the ventilation is secured, and catheters are reconnected, and the arms and legs are pressure free. Next. So when can you stop pronation? Proning can be terminated based on the local guidelines. It is important that when we are proning an intubated patient, that patient should be proned for about 16 hours. And then when we see that after supination, the oxygenation is sustained, so we do not need to prone the patient. And one fact is that you can offer CPR in the prone position as well. And it is a very interesting fact that yes, if the patient becomes asystolic or develops arrhythmia, then we can offer CPR with prone positioning as well. So this is the role of a nurse. Again, if we see that the patient is hemodynamically unstable, patient is tachypneic, tachycardiac, and desaturating. So here a nurse must know that at this time, the patient requires critical management, right? And this critical management includes non-invasive ventilation, BiPAP, CPAP, or high flow nasal cannula for improving oxygenation, restrict the fluid resuscitation to be sure that that we do not give further edema, or we do not the patient do not develop further consolidations in the lung, right? And then the third is awake pronation. If the patient has GCS of 15/15, is able to follow commands, right? If the condition of patient improves, then we may continue with this treatment. And if, for example, the condition of the patient starts deteriorating or it does not improve, then we may have to give invasive mechanical ventilation trial with low tidal volumes, with low inspiratory pressures, with high PEEP, and with proning of about more than 16 hours, right? And we will be discussing about this invasive mechanical ventilation in our further talks of this series. So next. So this is again a question for you. One of the common complications of ARDS is damage to the lung cells which produce surfactant. An ICU nurse should know that. As an ICU nurse, you know that this will lead to. Do we have a poll for this?
Yes, there's a poll running as we speak. I can tell you that the most common answer at the moment seems to be atelectasis and lobar consolidation, followed by bronchoconstriction with increased wheezing, followed by upper airway obstruction, and then in the end they have said airway secretions. So share results. Here you can see them.
So yes, most of you have answered correctly, and so very good.
Okay.
Yeah.
And then we go to the remaining P's. Sorry, I'll just take over from here, Nasreen, if that's okay. The remaining P's are going to be protective lung ventilation, which is the next talk, which will not happen next week. This talk, we are not going to do any talks next Saturday because it's Eid. And so every other talk, the rest of the series will start from the 8th. Poor nutrition is the talk which will be after the 8th. And of course, protocolized weaning is the talk after. So what has happened now is we have come to conclude or agree that this patient has developed ARDS. We cannot offer awake proning because the patient has contraindications, i.e. they are delirious and confused. And so in the next talk, we are going to move on to intubating this patient. Here is a link for the feedback. Your questions, please send them. We will try to answer them before we start the next session. And have a wonderful weekend and a wonderful Eid. Thank you.
Thank you very much, Mohsin, and everybody for participating.
Thank you. And
Thank you so much, everybody.
Okay, I think we need to go to the other one now, don't we?
Yeah,
okay.
Is that going to be the same, or we have to move to the next one?
It's a different link, I think.
It's a different link. Yes, it is.
Okay, see you guys there.
Okay, we'll see you.